So you're struggling reaching overhead, whether it's for handstands, if you're doing handstands, whether it's overhead pressing or any other exercise, or just like getting into your overhead cabinet. We're going to go ahead and discuss what all is contributing to that motion, because it's a lot more than you think. We're also going to be going over how to assess and see what is contributing, and give you a couple things to dive a little bit deeper into that and address that. These exercises are not necessarily an end-all be-all as well, so do take that into consideration. There's a ton of different exercises out there, and these are just a couple examples.
So to start, we're going to talk about the 4 joints that comprise the entire shoulder complex. So for you to raise your arm up overhead, all 4 of these help play a role in that. And in reality, most people just think about the one right here, that ball that you can kind of look at very easily. And that's also the one that for most people is the one that hurts, right? Or that they think is most limited. And if you just only assess that one, you're not going to find the best results. So you also have and that's called your glenohumeral joint. It's really your shoulder blade and your upper arm, and where they kind of match.
So you have the ball
as a ball and a socket. But the socket itself and the shoulder blade has a quote-unquote joint, so to speak. You call it your scapulothoracic joint. That's more where your shoulder blade kind of orients off of your thoracic or your mid-back, so to speak. And the biggest thing with that is it really doesn't even have a ligamentous attachment, so to speak, or it's not really a pure joint. That's why some people actually don't consider it a joint. So it's really important, and we'll talk about this later, to understand and assess how the muscles are helping play a role, whether that's just their ability to fire or even their physical definition and consistency, and how that's going to play a role in the positioning of that socket. Because you could have the best ball in the world, but if the socket's not too good, it really doesn't matter in really anything in life, let alone just human anatomy as a whole. Another joint's going to be your AC joint. That's kind of right here. Long story short, so a lot of people might have top. If it's painful, obviously there's a bunch of things it could be, but they'll frequently present on the top of the shoulder or the front. The most challenging positions for this joint, if it's irritated, is going to be either across the chest, out to the side, especially pretty much even with shoulder height, and then more the extremes of overhead motion. And then if you just trace that in a little bit more, it's what's called your SC joint, and that's really where your sternum or your chest plate kind of attaches to that same collarbone, and that is probably going to be the same things that either get aggravated with it, but not too many people really voice that they have pain at this spot. It's more of a thing that if you can improve the motion there, it'll help the other spots. So that obviously applies to literally all of these. And in terms of trying to improve the motion and how it can take stress off others or optimize performance elsewhere, it just so happens to be that the SC joint is probably the least likely one for most people clinically to say that that's hurting me.
Yeah, and it also doesn't have that much motion to begin with there, so it's a pretty stable joint to begin with. So. And then you also want to consider the thoracic spine and ribs, because that's going to impact shoulder motion as well. It's not really part of the shoulder complex per se, but it can impact the motion of the shoulder. So we're also going to talk about that as well.
And cervical spine.
Oh, yes, and cervical spine. Yeah. So you also do have a ton of muscles that attach to the shoulder. We're going to dive a little bit more into these a little bit later, but all of these, whether they're attaching to the actual shoulder joint, so the glenohumeral joint, are going to play a role. So like the rotator cuff, any muscles that help stabilize the shoulder blade or scapula are also going to be important in how the shoulder moves. But you also have some of the chest muscles and the upper arm muscles that are going to impact the shoulder. So we're going to dive into that a little bit more later and chat about that. But it's not just joint, it's also muscle.
Well, if you're just really looking at just pure motion, you can kind of tease it out joint specific. So the glenohumeral joint, or the big ball in the socket, again, the one that most people refer to as their shoulder in isolation, it typically has about this much out of the full 180 that you'd ideally have. Usually about 120 degrees is from the glenohumeral joint itself. typically the first portion of your arm motion is just glenohumeral, and then after that, some of the other ones start to play a role. Common, easy thing, again, none of these should really be with pain, but this is one of the ones that you'll just see a lot of times. You've seen a baseball pitcher or softball pitcher kind of stretch this ways. I shouldn't even say pitcher, just anyone that plays the sports. And you'll just kind of go across like this. It's practically the easiest thing to do, assuming it's not painful, that most people don't realize why they're actually doing it. They might say, oh, they're just stretching. And to be honest, when you're first coming up and learning these sports, you don't know that's why you're doing it. You just know you do it because that's what you're supposed to and that's what you're taught to do.
And with that, you want to be feeling in the back of the shoulder because, again, we have mentioned the AC joint before. And so if it's painful in the front of the chest, then you're just cranking on the AC joint. So you want to feel it in the back with this stretch. So do keep that in mind. If you feel it in the front, then another stretch or mobilization technique is going to be more indicated.
That's when typically in the rehab setting, most people that we work with are not just getting here like you're a pain-free, throwing athlete. So what we'll usually do is have them anchor their hand onto something like a door handle. Sometimes we use bands, cable column, things like that. So you can actually, and just kind of lean away. So you can get the separation in that and stretch without specifically putting it in the position that just pinches on some of those anterior structures of the shoulder complex.
And then going into how the shoulder blade moves. So if you do take the shoulder and you go ahead, raise the arm out to the side, you're going to start to see that shoulder blade move up and kind of pop out to the side as you go up. And that last 60 degrees or so, 60 of the 120 degrees does come from this joint, about give or take depending on the person. So you do want to consider the motion of that joint into why. So if that is stuck, then you might only be able to get to here or so without getting or working on that motion. So some things that we might do in the clinic would be just laying on your side and bringing your arm out to the side, really getting a stretch through those tissues. So you hear, and then coming up overhead, notice how the shoulder blade comes up, and you can even use your other arm and kind of assist it a little bit and kind of grab it and pull it up, depending on your motion as well. You can also do scapular circles. So coming here and going around, or even just a retraction and depression. So you're pinching the shoulder blades down and back with that, just to kind of loosen that up. And then you can even go into a push-up position or on your hands and your knees and start to work that motion that way as well. But often, a lot of times with that overhead motion, I personally like the side lying exercise, and then also getting my hands on the person and actually moving that shoulder blade themselves, or myself, so that they can then get into that motion. But you can also do it if you're potentially even walking up a wall, and you can kind of grab back and assist that too.
This is a really big one again because it has a lot of that portion of the motion, and it's really married to the fact that muscles and their activation really impact the position of this joint. So even if it hurts here as you bring your arm overhead, it, again, ball, socket, right? Either one of them can be the issue. This is just not usually the thing that people say, oh, it hurts there as much. It's more contributing to the problem, and that's where assessment by someone else is typically needed, because it's really hard to see back there yourself. Next one would be the AC joint. PT school, literally, they teach you the easiest thing to do is just take their arm, bring it across the chest, and see if it pinches. Obviously, not going on too much of a tangent here, a lot of shoulder tests that they teach you in PT school, they're really not that great. That'll be a topic for another day about how specific they are to testing what they say they're testing, how likely they are to actually create symptoms. A lot of the shoulder tests are going to cause symptoms, but that doesn't mean that it's for what it says it's testing it for. So grain of salt here.
And then
the long story short here, which is more or less the easiest thing to do, you can try to move it yourself. It just doesn't work very well, to be honest with you. You can try. I'll do sometimes where I'll put my hand up on the top of the, collarbone there, and you can try to move it as you push down, but it's just very tender for a lot of people. So really the easiest thing here is just have your arm out to the side, again, holding on to an anchor point or something, and just lean away.
And so typically I like to keep it about like 30 degrees or so. So you're holding on to something, whether it's like a doorway or a cable column or something like that, and just kind of like leaning away. You're not trying to pull it at all. You're relaxing, just gripping, and then leaning away, and you should feel a good stretch through that area.
I mean, personal opinion is if it's more aggravated, I'll go there, but typically I'd rather, like me personally, I'd rather be at this height because complicated physical therapy reasons I'm not going to get into. But again, pain-wise, not as many people can tolerate up here, which is why you do that more frequently. But to me, if it's not a problem, I'd rather be up here. However, I will say that if you have it down here more, you can more easily tie in some neck stretches while you do it by getting all this down and stretching it as you lean away. So again, depending on what your goal is, there's more than one way to eat Reese's.
And then kind of circling back to like the tests that we do, you also do want to consider an MRI. A lot of people think that's like the end all be all, but that doesn't necessarily show everything. And then even if it does show something, it might not be related to your pain. So a lot of people have rotator cuff tears, like maybe some arthritis or things like that, and they don't have any shoulder pain or anything like that. Like, I feel like there was a research study, don't quote me on the numbers off the top of my head, but like a high percentage of like rock climbers, for example, had rotator cuff tears and didn't have any pain. And like, baseball players have slap tears, so a tear in their labrum, and don't necessarily need surgery to like repair that, and they're able to get back to their level. So even though you're seeing something on an MRI or something like that, does not necessarily mean you're doomed to have pain for the rest of your life. If you improve how that joint's functioning, if you improve how the muscles are working together and the strength, that can address some of the issues. So.
Yeah, and two other things on that real quick. Number one is over 50% of people 50 years or older have some type of a partial rotator cuff tear with no history of shoulder problems at all. There is some random person walking on the street that's over 50 and, flip a coin, they're going to have a partial rotator cuff tear at least. So to her point, that really doesn't mean anything in terms of what's medically causing your symptoms. Unless you kind of get analyzed by a medical provider with what actually is, your physical presentation in conjunction with your, issues that you voice, and then you combine that in there. And then the second thing on that too is the MRIs themselves for the shoulder is probably actually the worst joint in the body, in terms of its accuracy. If it's on there, then you have it, so to speak. But it'll miss a lot of things as well.
Yeah. And I can kind of speak to that personally. Yeah. So I had to have shoulder surgery back in 2020, and my MRI only showed a posterior labrum tear. So I was like, I've tried rehabbing it myself. I failed conservative care. So that's why I opted for surgery. And so I was like, the surgeon was even like, you don't really need it, but like, if you want me to, I can. And I'm like, I've tried everything else. It's limiting my function. It's causing symptoms. Let's do it. So they did find a slap tear. So a different spot in the labrum was torn. I did also have a rotator cuff tear, like a full thickness tear of one muscle and then a partial thickness of another. So do keep that in mind. Like, it's not always the case where you're going to find more in there, but that can happen. Like Steve said, it doesn't necessarily show everything. And then with that being said, I had that full thickness tear of one muscle, but I also had a partial thickness of another, and they did not repair that muscle. And I don't have shoulder pain now. I did my rehab, etc., so forth. And so just because it was a partial tear does not necessarily mean it needs to be surgically repaired. So going into another joint that can contribute, so your first rib is actually a lot higher than you think. So if you go behind your collarbone, you can actually feel it. So you have the collarbone here, and then you like dive down in there, and it might be a little bit tender depending on you, but you can feel your bone and rib there, and that can impact your shoulder motion. So how we would look at this in the clinic is honestly turning the head all the way to the side and then bending it forward and seeing how far that goes. So turning it there and then coming forward and then comparing it to the other side. And so if it's significantly restricted on one side versus the other, then you might have a little bit tight for sure. You can kind of do it yourself, but it's kind of a little bit challenging as well to do that. But with this, it can impact like that end range shoulder motion as you're getting up there as well. So doing a self-mobilization for that to loosen it up. And it can also impact like how the neck feels and things like that too. So a lot of times I'll grab like a strap or something like that and wear it around like a sash. So you have it here and then you can just lean, you can pull down on it and then lean away. So essentially coming there, going away. And then you can also incorporate some shoulder motion as well, going out to the side while having that strap there. I'm gonna go ahead and grab a strap real fast so that would show that to you. So with the strap, Steve's gonna put it around his shoulder there and wear it like a sash, grabbing both, or like a purse or something like that. So you want it right next to the neck, not like on it or out to the side. You want it kind of right next to the neck to get it really on that first rib there. You're pushing down with your other hand, and then you're gonna bring your head over to the side, and you should feel a stretch right on the side of the neck there. And then as that gets easier, then you can even pull down and then move your arm out to the side, forward, or you can even walk your hand up a wall if that is like uncomfortable. So you can kind of go up and then you can kind of lean into it and get a good stretch there too. So kind of walking up and then leaning into it. Still pulling down on that strap to address some of that there.
Another portion of your body to consider when trying to get that arm fully overhead, or just to, depending on what your goals are, just even reaching for a cup in the cabinet, is your actual mid-back as well. This is probably one of the things that stood out from the residency program that we did through Upstream Rehab Institute, was how good of research there was for joint mobilizations and manual therapy to the mid-back to help with shoulder range of motion and shoulder pain. So in theory, you'd want to tie that in a little bit to what you're doing from a programming standpoint, if that's one of your goals, even if it's not a pain-specific goal and just trying to improve mobility. Doesn't have to be manual therapy specifically, but in a clinic, we'll literally, try to do mobilizations and manipulation all the time of people's mid-back if they can tolerate it, if they're safe and it's appropriate. I do it every single day that I treat to improve shoulder mobility in patients. So something that y'all might want to consider doing at home as well.
Is adding some of the mobility work, not necessarily manipulating yourself, but
correct.
Yeah.
So Laura's going to show you a few exercises that she personally likes to do for this. I think sitting is a very big issue for a lot of people.
Yes.
Whether that means literally sitting down at a desk or in an office or just driving, and it kind of brings you forward a little bit. So she's going to show you some exercises that she does kind of throughout her day, try to incorporate, not that it has to be during your day that you do it, but it might literally just be kind of as something from a movement diet standpoint you add to, kind of balance your body out from some of those prolonged positions.
Yeah. And these can also be used as a warm-up before you work out as well. So there are a couple different ways that you can do this. So I like to you can use a peanut, which is like kind of almost two of these connected to each other, or you can use two tennis balls or lacrosse balls, and you can put it kind of on the mid-back. So you're going to be laying on it, and you want it to be kind of somewhere stiff back in here, one on either side of the spine. You can also do this with a foam roll, laying on it kind of on the mid-back there. And then grabbing a stick or a dowel of some kind. You don't technically need that, but I like it if I'm working a little bit more of that shoulder motion just to get there. So Steve's gonna be laying on his back. You're gonna kind of lay them down on the ground, find a spot on the mid-back where it's a little bit tight or stiff. And you can kind of do a couple in each range and then move it slightly up or down. And then you're gonna go starting at the waist and then going overhead, trying to keep those ribs tucked down. A lot of times you're gonna arch that back, and that's just you're not gonna get as much out of it. So you're really gonna engage your core and tuck down there. And then you can kind of adjust based on where you're tight. And you can even add that breathing in there. So going up, kind of taking a deep breath in, and then breathing out, and then coming down. So make sure you are not necessarily holding your arms out super far to the side. As it loosens up, you can get a little bit closer and a little bit higher, making sure, again, those ribs are staying down there. And if you don't have tennis balls or lacrosse balls, you can also use a foam roll. So it does the same thing, it just provides a little bit more like hinging over a bigger object. So you can do that without the dowel as well. If you don't have a dowel, you can just interlace your fingers or just kind of keep your hands right overhead. But you can get a good stretch this way just to loosen up the mid-back. And it honestly feels really good.
And then what we'll do with some people, if your neck kind of aggravates you from that, or if you can't get all the way, two options. Number one, get your hands just behind your head instead of going overhead like this. Or option two would be either some pillows underneath your head, or you can just bring your hips up as well, so that way your neck can kind of make it to the ground instead. So those are two modifications if you don't quite have all that mobility, or if you start to get some neck discomfort while you do it.
And then to specifically work the rotation, because the rotation kind of pairs with that overhead motion too. So the mid-back can loosen up a lot of times into rotation versus like the leaning back a little bit easier, is open books. They're like one of my go-tos. So bottom leg is straight, top leg is bent, arms are out in front of you. And then specifically if I'm working any sort of shoulder motion, I like to add a little bit of an overhead circle. So just trying to keep that hand on the ground for as long as you can, going around and then coming back, making sure this knee is staying on the ground and actually making sure you're twisting through the mid-back. A lot of people will try to keep that shoulder on the ground without actually rotating that shoulder. You're twisting and rotating that back. So from the side here, coming all the way around, making sure the shoulder is dropping back. You can even keep this arm on your knee there and coming around. But that honestly is a great one.
I'll commonly just tell people, try to keep your eyes in focus with the hand that's moving, and that'll kind of help cue people to just make sure that even if you forget or not, you're just moving through that mid-back as well. Because there's no way I can see back here if I'm not having my body twisting with it. So sometimes that's something that'll help people out with that.
Going into more muscle-specific things, you do have 17 different muscles that attach to the shoulder blade. So all of those muscles are going to play a role in how that shoulder blade moves and then impacting how the shoulder joint moves itself. You also have the rotator cuff muscles, commonly called the rotator cuff muscles. It's actually rotator cuff with Fs. It is your supraspinatus, infraspinatus, teres minor, and subscapularis. So different parts of those muscles attached to the shoulder blade and then right at the top of the shoulder. So a lot of these shoulder muscles can refer to this area, which is where you might feel it. And it might be coming from elsewhere, a little bit farther back in here. And then you do also have like your biceps, your triceps, all attached to the shoulder, and then even your chest muscles too are going to impact how the shoulder moves. So if these like muscles are tight in the front, you're not going to be able to get your shoulder into a more optimal position. So taking all of these into consideration with what you're doing and how the shoulder joint's moving itself.
And that really ties into one of our challenges, when we're evaluating the shoulder in the clinic is there's a bunch of different things that we can kind of start placing the blame on. And a lot of people point at like, oh, it hurts here, right? Again, not everyone has pain when you're starting to talk about this forum specifically, but in the clinic, I need to figure out what the heck it is that's causing this to only get to here, right? And, we talked about the joints previously, but we do need to analyze all these different muscles in terms of their recruitment, their actual endurance and strength, and then their flexibility as well. And it's really tough to do that on your own. So that's kind of one of the things that, just looking at where it hurts really doesn't mean much, to be honest with you, with us from an assessment standpoint in terms of what's actually causing this. Unless there's a, more traumatic incident where it's a little bit easier to kind of try to, figure it out. But taking all that into consideration, when people see us in the clinic as physical therapists, we're kind of playing detective, so to speak, at which of these muscles is the problem, so to speak, whether it's endurance, flexibility, just recruitment. It might be strong, but it's not firing at the right time or in the right sequence. Some of these muscles have kind of force couples where they kind of work as pairs, and it can get very complicated. It's very hard to say just my arm can't get overhead all the way, and we'll try to rule out joint things and see how that impacts it. But it's really hard to kind of analyze this stuff yourself, to be very honest with you. And that's where, seeing a healthcare professional or movement specialist is really helpful. If you are missing that motion, you've tried some corrective exercise, maybe yourself, whether that's just some stretching or, just strengthening some surrounding muscles, you're just, not getting the results that you're looking for. You really need to see someone because it can get very complicated.
Yeah, there's many things that can be going on. And there are, we can bias certain muscles in how we test the strength too. So then that can also help us get to where we need to be. And you can't really do that yourself too.
It's real fun. It's real fun watching people be able to bench 300 pounds and then they're really struggling to fire their arm a certain way. And, that might actually be the limiting factor. It's kind of funny when they can get a little disheartened by it. They're like, this is a good thing because
we know
you're
now.
here for a reason. Now I can figure it out, whereas you haven't been able to figure it out. So it's kind of funny in that way, but it sometimes takes them a few seconds to realize that it is a good thing that that's not working too well.
Yeah. So if you are interested in learning a little bit more on how the shoulder functions, maybe some specific exercises, I do have a shoulder prehab program, which addresses some of the strength of the smaller muscles, including the rotator cuff, scapular stabilizers, and also does include some mobility as well. But again, if you do feel like you need an individualized assessment, please seek out care from the appropriate medical provider as well. And if you do find this video interesting and want to learn more a little bit about your body and things like that, go ahead and watch this playlist here. It has a ton of videos for you about the body and movement and things like that. Getting into your overhead